So I'd like to start by thanking the organizing committee to invite me to this conference. And I was asked to give a talk about the advances in PET-CT and PET-MR imaging. This is a very wide topic, and I felt, given the fact that there is going to be a session on PET-MR and clinical application, perhaps maybe I should concentrate on PET-CT at the time being, given the short duration for this session. So I have no disclosures to give. So the outline is we're going to talk about several components that have been advanced in PET-CT, motion suppression, time of flight, and point-spread function reconstruction, long axial field of view or large axial field of view, continuous bed motion. We do have the digital type detector, solid state photomultiplier tubes, or what we call then regularized reconstruction. So let's start with motion suppression. In PET imaging, we need to differentiate between what is motion blur and mismatch between the PET and the CT images. When we talk about motion blur, we know that the PET scan takes a relatively long period of time to acquire the image. However, if the object that we are taking a picture of is moving, then the images would be blurred as such, when in reality the object should look of this nature. Now, in order to minimize the amount of motion during the PET acquisition, historically we acquired PET data in what we call gated acquisition, whereby if this blue trace here is a patient breathing cycle, then we divide the patient breathing cycle into multiple bins. In this case, we're showing 8 bins in one breathing cycle, and then the same breathing cycle continues for the second cycle, and then the same bins are given accordingly. So data that's acquired in bin number 1 will be the same as data acquired in bin number 1 in the second breathing cycle. And you can add this data to that data, and as such, continue from bin 1 to bin 2 to bin 3, and so on and so forth. Whether you put 8 bins or 10 bins, that is a user preference, but you can generate images that suppresses the motion or reduces the amount of motion. We call that gated PET imaging. Now, of course, whenever we do gated PET imaging, we need to match CT data associated with this, so that for every particular location of an image in a breathing cycle, we need to have the proper attenuation map. And for that, we also, if now this is the breathing cycle of the patient, we acquire multiple CT data during the breathing cycle to match every particular image in the PET data. So for this bin, there will be a matched CT, and so on and so forth. And we call that then 4D CT acquisition. And when we match the CT data with the PET data, that will be known as 4D PET CT. And with that, you can see that without any gating in the PET image, there's a patient here that had a lesion that is at the dome of the liver, and because the dome of the liver moves up and down because of patient breathing, the lesion is blurred, and the activity concentration, or what we call the standardized uptake value, will be underestimated compared to when it is gated in this case. And you can see here the lesion is much easily visible, it's more circumscribed, and the SUV value is much higher. However, this image here is characterized by some noise. You can see here we can then play these images 4D PET-CT, and you can see the motion of the lesion during the PET acquisition, but since it's gated now, you can follow this motion very easily, and the CTs are obviously matched with the respective PET data. I wanted to mention that when we do acquire gated PET data, the images are relatively noisy, as you can see here, compared to that image, because there is much less data that is being acquired in this case. Now, there are several approaches to recover from this situation. One is to take these images that were generated in the gated image and then try to register the images to each other. You can do this registration in image space. One manufacturer does that and call this approach Q-freeze, or you can do it in sinogram space in the raw data that's been acquired in the PET scanner. And during image reconstruction, you can adjust for the motion and generate a final image without any motion blur. That is known as IMOCO from another vendor. Siemens in this case calls that as OncoFreeze, compared to General Electric that calls that QFreeze. Image space versus sinogram space. When you look at these next to each other, this is when we acquired the PET data without any motion correction. You can see here the lesion is blurred out because we did not correct for motion. However, with the image-based motion correction using gated type acquisition, you can see here the lesion is much clearly circumscribed and it has a much higher SUV. As you can see here, it's a much more concentration of the activity. While in the approach whereby the motion correction is done in the sinogram space or in the raw image, the raw data space, also we get the same type results. Again, QFreeze, OncoFreeze versus static type acquisition. Now, all of these techniques now are currently available from these manufacturers, and you can get that option available on your scanner. Another approach, rather than acquiring the data into multiple bin, is to leverage the fact that the patient breathing cycle is not really sinusoidal in nature, but it has actually a large resting state towards the end of expiration. And the idea is to acquire the PET data during that time of the breathing cycle. That type of an acquisition is available on whether you do it on GE type scanners or on Siemens type scanners. And the GE name for this is known as Q-static. The Siemens name for that is HD chest. The GE uses time binning, so it looks for the time in this location, whereas Siemens looks for the amplitude in that particular location. But the idea is the same, whereby we're acquiring PET data at a location that has relatively little motion to generate the final image. Just to compare images, you can see here the patient data without motion compensation. You can see the lesions here are blurred, and then when you correct it, it's corrected nicely. And similarly, on the Siemens type approach, you can see here there are multiple lesions that are blurred out. And now when you apply this other technique, the HD chest type technique, the lesions are much clearly visible and the activity concentration is no longer blurred out. Now, to do any type of such acquisition requires devices that will track the patient breathing cycle. Historically, the PET field used either external video cameras, infrared cameras, or they used a pressure belt whereby as the patient is breathing, there is a change in the resistance on that particular breast, and that can be of that belt. And as such, you can track the patient motion accordingly. These require lots of intervention and are not easy to utilize in a day-to-day basis. Newer approaches utilize what we call data-driven gating. So the patient breathing cycle is directly extracted from the acquired PET data itself. And there are multiple techniques for that, whether it is based on the sensitivity of the scanner, whether it is image-based or sinogram-based. But you can see here, as the patient is breathing or moving, there is a change in the image because of the location of the tumor, as well as in the sinogram space. And we can use these changes in order to track the patient breathing. There are several approaches to extract that information that I have mentioned, whether it is image-based or sinogram-based. And here the slide shows several publications that have shown this. You can see this is now dating back actually quite a while in this regard. I have talked about motion blur specifically, but it is important to note that there is also the mismatch between the PET image and the CT image. We talked about 4D PET CT to match them together. But again, the general idea is that in PET CT, when you acquire the CT scan, the CT is acquired at different parts of the patient breathing cycle. It might be here or here or here or here or anywhere in the patient breathing cycle. So it captures a single state of the patient breathing cycles, whereas a PET scan is acquired over multiple breathing cycles. And as such, there will be a mismatch between the location of the tumor on the PET and the CT, and has some ramification on the activity concentration because it's not anymore properly attenuated, corrected. And you can see here, this is a relatively old slide from our institution, whereby you can see, because there is no matching between the CT image and the PET image, it has this characteristic view whereby there is a photopenic area here at the top of the liver, as well as if you have a tumor in the lung, this tumor will appear with low activity concentration because it's not properly matched with its CT data accordingly. You can see here much clearer, if you have a tumor on the CT image, you cannot see it on the PET image, and as such, that tumor will be underestimated as far as activity concentration is concerned. So one approach to try to recover from that error in mismatch is to say, since this PET data is acquired over multiple breathing cycles, why don't we do the CT to be done in the same way? So in this case, we acquire multiple CTs over the patient breathing cycle, but then we average all these CT together to generate what we call an average CT. So now we have a PET scan over multiple breathing cycles, we have a CT over multiple breathing cycles, and these will be matched with respect to each other. And I show you here, these are some slides from my colleague here at MD Anderson showing the acquisition without average CT and then with average CT. And you can see here, this photopenic area is no longer visible. You can now, it's removed. And then this tumor has now much clearly visible in this case. It is much more circumscribed. And then the SUV has increased by a large amount. Whether you do that in oncology type application or in cardiac type application, you can see here that the PET and the CT are not properly matched. You can see the heart on the PET image is not overlaid properly on the CT image. And as such, when you go look at different axial slices, it appears as if the patient has an infarct, but in reality, that is primarily because of the mismatch between the PET and the CT. And when we adjust for that using an average CT, you can see now that the heart is very nicely described in this regard. However, right now, there are no techniques that are currently available that matches the PET data with the CT data. We can create average CT, and that is available on different manufacturers, but we cannot acquire a single CT and a PET scan and make sure that the CT data is matched in the same location as the PET data. Because the PET, is, like I said, is acquired over multiple locations. Even if we create a gated PET scan, it will not match the CT data accordingly. And there are no such techniques in this regard. Let's move to look at time of flight and point spread function type reconstruction. You can see here that in conventional PET imaging, whenever there is an annihilation event that occurs that is detected by the two opposing detectors, when you reconstruct the image, there is no information as to where did the annihilation event occur. So the line of response is uniformly distributed across the incidence of the annihilation event is uniformly distributed across the field of view. We cannot identify whether the event occurred here or here or here or here. We just know that something occurred along this line. Whereas in time of flight, we also, in addition to capturing an event occurring in this detector and an event occurring in that detector, we capture also the time that these events occurred. And by us identifying the time of arrival of these events into these detectors, we can then pinpoint where did the event occur with better accuracy. So rather than it's uniformly distributed along the field of view, we can now pinpoint it more accurately because we know that these photons are traveling at the speed of light. We know this particular distance, so we should be able to pinpoint the location more accurately. This is what is known as time of flight imaging, and it's currently available from all manufacturers. As a matter of fact, most current PET-CT scanners come with time of flight imaging. It has been shown that time of flight imaging will improve your signal to noise ratio with an improvement that is equivalent to the square root of the object diameter divided by that position information. So when we talk about delta X, it is the error in positioning where did that event occur. So this is what this delta X is. So as the timing resolution of the scanner gets better and better, so this is here 1200 picosecond, 500 picosecond, 300 picosecond, 100 picosecond, you can see that we can identify the location of the annihilation event more and more accurately, changing from 18 centimeter all the way down to 1.5 centimeter. And as such, this will result in an improvement in the signal to noise ratio of your image when it's acquired with time of flight compared to conventional imaging. And the improvement is by either like 1.6 times, 2.1 times, or 3.7 times, and so on and so forth, depending on the object size. So for larger objects, there is a tremendous improvement in identifying in signal to noise ratio. So patients that are large will have more benefit from time of flight imaging compared to imaging patients that are relatively small, or when you image the brain in this case, which is a relatively small structure. Currently, time of flight machines have timing resolution in the order between 500 picosecond and 250 picoseconds. Actually, some scanners out there from some manufacturers that are breaking the level of 200 picoseconds. So we are really moving closer and closer to having really very, very improved signal to noise ratios compared to conventional type machines. These are the original slides that were done on the first time of flight machine. This is courtesy of Joel Karp, showing that without time of flight imaging versus time of flight imaging. And you can see there are some improvement in the signal to noise ratio in areas like in this case over here, as well as in this case over here. Now, this is at a time when the timing resolution was in the order of about 500 picoseconds, 500 to 600 picosecond. Now, like I said, since the timing resolution is in the order of about 300 to 300 picoseconds, these images would appear by far better than what you are seeing currently on your screen. And this is for a patient that is really very large with a BMI of 46.5. What's important to note is that when you acquire your PET data in time of flight, you can generate images both with time of flight and without time of flight at the same time. So the scanner that is capable of time of flight imaging, you can generate both type of images, and you can identify the advantage of time of flight versus non-time of flight imaging. A point of caution in this case is that when you do time of flight imaging, the SUV will be changed, obviously, because there is an improvement in signal to noise ratio. The SUV with time of flight imaging will be higher than the SUV when you do your reconstruction without time of flight imaging. Let's look at the point spread function reconstruction. We know that in a PET scanner, the resolution is not uniform across the field of view. So if you are in the center of the scanner versus when you move to the edge of the scanner, radially in this case, the resolution decreases. And that's primarily because the gamma rays that are going to hit, or the annihilation photons are going to hit the detector, rather than hitting it head on, they're going to hit it at an angle. And as such, rather than being detected in this detector, they will be detected in a detector that's adjacent to it. And that becomes even further and further worse as you move further and further to the edge of the scanner in this case. Since the scanner is designed in a specific way, and that is a physical construct of the scanner, we can identify the resolution loss from the center of the scanner to the edge of the scanner and model that as part of our reconstruction. So we know if we had an event that is at this location or at that location or at that location in the field of view, that will result in a certain amount of loss of resolution. And as such, we can recover from that loss during the image reconstruction process. That approach is known as point spread function reconstruction. It's been around also for a while right now, but I am trying to provide a historical aspect, or the options that are currently available on your scanners, and that you should be aware of regarding advances in PET imaging rather than standard PET imaging. Again, because you can improve the resolution in the scanner, that will imply that you will have changes in the activity concentration, because now you can see tumors much better. And as such, it will impact the SUV value in these lesions. You can see here, the SUV of a lesion is changed dramatically. This part of an increase is also a little bit artifactual, because the correction itself introduces some error during your image reconstruction. We call that ringing artifact or a Gibbs artifact. flight because of that reconstruction approach. But if we combine all of these issues, this is a slide, a relatively old slide from Dr. Townsend. And you can see that standard image reconstruction, iterative reconstruction with resolution recovery in the middle panel and with time of flight and resolution recovery, you can see that the tumors become much clearly visible. However, their SUV will be different because we said that with resolution recovery, you increase the SUV, and we said also that with time of flight, you also increase the SUV of a lesion. So it's very important if you're following a patient from their initial scan to later scans that you always ensure that the baseline scan is done in the same way as your follow-up scan. Otherwise, the change in SUV will be primarily to these differences that are now available on your scanner, whether you're using resolution recovery or PSF reconstruction, or you're using time of flight reconstruction. Let's talk a little bit about large axial field of view. This is now the most recent innovation in PET imaging. And we can see that usually PET scanners used to have an axial extent that is in the order of about 15 centimeter to 20 centimeter. But now there are scanners that cover the whole axial extent of the patient. And that is the major innovation that has been happening with manufacturers, whether it's Siemens, General Electric, or United Imaging right now, that is a newcomer into the field and is providing scanners with very large axial field of view. Now, there are so many applications for large axial field of view, from being very useful for pediatric patient to doing parametric imaging and so on and so forth. And we're not going to delve into the detail as to why you would want a large axial field of view, other than to show what is the advantage of that. And the most important component is that you can cover the patient in a much shorter duration, because now the whole scan covers the whole patient. And as such, the sensitivity of the scanner becomes much higher. In this case, we're showing that rather than doing 5 fields of view, now you need 4 fields of view in this case. This is just moving a scanner from 15 centimeter to perhaps 20 or 25 centimeter axial extent. Now, at the from General Electric, they do have a scanner that is modular design, so you can buy that scanner in 15 centimeter, in 20 centimeter by adding an additional module, 25 centimeter by adding another module, and most recently by adding a 6th module that will make the axial extent of 30 centimeter. This will have, like I said, the ramification on the sensitivity of the scanner. Their machine is called the Discovery Molecular Imaging, or DMI, and the 3-ring machine, which is a 15 centimeter, has a sensitivity of 7.5, and you can see that moves to 14 to 20 or 21 at 5 rings. 6 rings, they are still just being introduced, but the idea is that this would follow. If you plot this, you will see that 15, 20, 25, so the 30 will be somewhere around there if you believe this graph, and this will be like maybe in the range of about 35 or maybe something of that nature as far as counts per second per kilobecquerel, which is the sensitivity of the scanner. This can be used in order to reduce your scan duration. So you can see here, this is a patient done on one of these machines. This is a 12-minute scan. This is a corresponding 8-minute scan or a 5.3-minute scan. This is really, these images are still of very high quality, even though we are acquiring this whole scan from eyes to thighs, taking just 5 minutes to be done, which is really amazing in this regard. You can do this in order to either do very short scan duration, these are 1 minute per bed, or you can do that by reducing the injected activity. Rather than doing the standard 10 millicurie injection into a patient, you can inject a very little amount of activity and still get relatively reasonable image quality. At the large extreme, we have United Imaging with the machine which is called the Explorer. This is a 2-meter machine rather than like a 15 or 20 or 30 centimeter type machine. This covers the whole patient. It has a sensitivity of 171. You remember we were talking about 20 or 25 or 30 or something of that nature. This machine has a sensitivity of 171 counts per second per kilobecquerel. It has also a very good resolution of detector elements that are of 2.7 by 2.7 millimeter. It has a timing resolution of about 430 picoseconds. So you can see here, if we are imaging a patient, putting in about 6.9 millicuries into that patient, you can see the images about 1 hour later. These images look really very, very nice. The whole patient is being imaged in one bed position. This is a scan of 14 minutes, the whole body in 14 minutes. Even if we wait and have the activity to decay to 2.2, 1.5, 400 microcuries, 160 microcuries, these images are still of very good quality. And we can use these type of images, obviously, to do now parametric mapping. So you can see, as you inject, you can see the distribution of this activity into the body. So the compounds that Dr. Bailey was just talking about, to see how they distribute in the body, can be acquired in a single acquisition, and looking at the activity concentration in different organs of the body, so that we can do kinetic modeling, or we can do dosimetry in a very easy and very simple manner. More recently, Siemens has just introduced, just a month ago actually, gotten approval for their Quadra machine. It's 106 centimeters, so about a meter axial field of view. Again, this is a very nice scanner with a timing resolution of about 225 picosecond. They report the effective sensitivity, which is related to the sensitivity, but not really exactly the same numbers. But I would be tempted to say that this machine would have about maybe 100 or so, maybe sensitivity in kilobecquerels per cc. So again, you can see that rather than scanning the whole patient as 2 meters in this case, when you do about a meter, you can always cover from eyes to thigh, irrespective of the patient habitus, whether the patient is tall or the patient is short and rather large. You can still cover a patient from the top of the head down to the thighs by using 1 meter. And that's the advantage of, rather than doing a 2 meter machine, you can do a 1 meter and still be able to cover the whole extent of the patient. This is here some pictures of that scanner with some information about it. And then I'm going to show some pictures that are extracted from these machines. These are first images from that scanner. These are MIP images, maximum intensity projection images. And you can see here, this is the distribution of the activity of a patient with FDG. This is about a 70 plus kilogram type patient. You can see the images are really of very high quality. You can also trade the scan duration from 4 minutes down to 1 minute, and you can still see a very good image quality in this case, whether you see it in coronal view or in sagittal view. You can see here coronal and axial view from 4 minutes. This is, the whole scan, we are looking at 4-minute scans or 3-minute scan or 2-minute scans and what have you. I see I am running out of time already. So I'm going to perhaps maybe talk about digital detectors rather than continuous bed motion, because that is really an innovation that is now being used by the majority of manufacturers. Usually in photomultiplier type detectors, when an incident event occurs at a detector, the photomultiplier will try to position that event by using angle logic rather than to be able to pinpoint that event more accurately. Whereas in digital detector, we can really identify where did the event occur specifically in a one location versus another location. So this would improve the image resolution, because there is no detector positioning regarding to angle logic, and will also have an improvement in sensitivity, because usually the photomultiplier tube has a variation in its sensitivity across its surface, whereas this does not occur in a digital type detector. So there should be an improvement in sensitivity, as well as an improvement in resolution whenever you use digital detectors as compared to analog type detectors. So these are the analog type detectors, and I'm going to show you here a picture of a digital detector that is from one of the manufacturers. So this is the scintillator here, and it's sitting on the silicon photomultiplier tube in this regard. Like I said, the different manufacturers now provide digital type detectors. These were originally developed for PET-MR machines rather than PET-CT scanners. And from General Electric, like I said, they come in either 15 centimeter, 20 or 25, or even now 30 centimeter. Siemens also has digital type detectors. Now, unfortunately, there are no scanners that we can compare exactly digital detectors to analog detectors that I am aware of. But these machines are relatively very similar to each other, although the crystals are slightly different from one another. I'm showing you images from the JZAC Phantom, and you can see that perhaps with the digital type detector, you can see this sector here, the 4.8 millimeter sector, a little bit better than you would see it on an analog type detector. I'm going to end by talking about regularized reconstruction. This is an important issue, rather something similar to what Dr. Bailey was talking about, using novel reconstruction type approaches. The idea when you do iterative type reconstruction is that as you increase the number of iterations, you will have more and more noisy images, but you can see the lesions more and more accurately, and the activity concentration will be more or less truly depicting of the underlying activity concentration. However, no radiologist would like to look at images that are this noisy, and as such, we always stop our reconstruction at a relatively early number of iterations in order to create images that are relatively smooth. By doing so, the activity concentration in a lesion will be underestimated. It's not the true activity concentration. And the idea is, how can we continue to increase the number of iteration, which will result in an increase in the image noise, but at the same time, improve the activity concentration in a lesion of interest, or improve the contrast, but without increasing the noise. So the idea is, rather than move from here to here, we would like to move from here to this place in that regard. Now, that is done by using regularized type reconstruction, these novel, innovative reconstruction algorithm that allows us to do so. And I'm showing you here some images in that regard of the JZAC Phantom. You can see here 5-minute scans all the way down to half-a-minute scan. They become noisy. This is standard reconstruction, and this is with regularized reconstruction. And you can see things appear much better because we are able to minimize the noise in the image, and you would improve the contrast in your image. Again, back and forth on the JZAC component. And again, on the contrast part, this is the standard reconstruction, and this is with regularized reconstruction. So you can see there is an improvement in the image quality accordingly. I'll show you some images related to that. You can see here, this is just with point spread function reconstruction. This is point spread function with time of flight reconstruction. Regularized reconstruction has a manufacturer name. It's called Q-Clear. Here, Q-Clear with point spread function reconstruction. And this is here when you add everything: point spread function, time of flight, and regularized reconstruction. You can see there are some lesions that you are not able to see in other reconstruction algorithm. That is usually very helpful in this regard. This obviously has impact on the activity concentration on the lesions. You can see here with regularized reconstruction versus without regularized reconstruction. You can see here the lesions will have a higher SUV compared to without this regularized reconstruction. So again, you need to be very careful when you are doing this type of reconstruction, especially if you have a baseline scan and you're following up the patient following therapy. So in summary, there has been lots of innovation in the PET-CT for the past 10, 15 years. It continues to dominate the nuclear medicine imaging field. Of course, now SPECT-CT, especially with its quantification, it's starting to come across. It has the potential to do new metrics rather than SUV. We can now do parametric imaging in these large axial extent type scanner. And this high sensitivity allows us to either reduce the radiation dose to the patient or actually do very fast scanning. So PET-CT imaging now can be done in the order of about 10 minutes per patient without any problem. In our institution, we do PET scans about 100 patients a day. On average, our PET patients take about 20 minutes. Hopefully, we are looking to get these large axial extent machine, and we should be able to do these scans in the order of about 10 minutes accordingly. I'm sorry that I exceeded my time, but I would like to thank the organizing committee for inviting me to give this